This bill was actively promoted by Johnson & Johnson and Norvo. You all know Fran Mangieri. And I want to call your attention to page 2, lines 7 through 15. And basically, if these companies agree to do this, and the definitions preceded this, then there should not be subject to any access restrictions such as preferred drug list, prior approval, or step therapy, or supplemental rebates. Now, we have a lot of bills right now, and Chairman Earhart certainly is very active in this area. I spent part of the interim on a study committee, a joint House-Senate subcommittee, looking at the whole issue of prior approvals. And I think with Jerry Dubberly and the gentleman who chairs, is that Dr. Perry? He chairs the Drug Utilization Review Board. We had some very good testimony, and some of the restrictions, quite frankly, that we place are unnecessary. And so Chairman Earhart introduced yet another bill this session to kind of do away with prior approvals. Now, I think that has gotten caught up in some misinformation related to this bill. And I just wanted to highlight a couple of points. First, we're talking at best 6 companies that would qualify based on the $10 million payroll requirement. And secondly, that with the Medicare D, and that's all of a sudden the state's obligation on the dual eligibles went away. And that was taken over by the feds with Medicare D, which is the prescription drug bill for Medicare. And approximately 60% reduction in the budget there. And now we have, effective in June and staged through the next several months, almost 1 million of our Medicaid people that will be moving from the supplemental drug rebate arena over to these managed companies, and that will be between they and the managed care companies. So again, the dollars that we used to get on supplemental drug rebates and some of the prior approvals has been significantly reduced by those 2 very significant events. So I don't want you to confuse some numbers you may have heard in the past, because as related to this bill, by the time it would go into effect, quite frankly, a significant reduction in what that is really going to impact the state. Meanwhile, offsetting that, and some of us believe substantially outpacing it, would be the economic growth of jobs. And we all know the spin-off effect and what that brings into the state. And certainly Commissioner Craig Lesser is very much in favor of this type of bill. Now, in fairness, I cannot tell you he supports the bill. We have explained the bill to him in concept, and he and the executive branch like the concept of something that would bring the pharmaceutical companies here. Some of the pharmaceutical companies, and I think, again, Fran Mangieri's company, particularly feel this is a fairly hostile environment for pharmaceutical companies because we extract a significant amount from these manufacturers in regard to their participation. If you want to be on the preferred drug list as a case in point, then you're going to give us rebates above and beyond what the feds require. And so that's part of the impetus that started this bill. So, Mr. Chairman, what I'd like to do, I'm not sure that either Fran or Lynn Bonson of Johnson & Johnson will be able to be here this morning, but they're really the driving force. Chairman Bob Smith, this was his bill really, but he asked that I carry it for him. But you'll notice he's a signator on it, as is Chairman Earhart. So what I'd like to suggest, if it's okay with you, if there's anybody to speak for or against the bill, then I'll come up, but I'll certainly answer questions if you want before those people. So your choice, sir.
Well, we have any questions? Make it quick if you don't know.
On line 24 on page 1,
yes,
the payroll less than $10 million. You mentioned 6 companies.
Yes.
How many would be affected if, say, you drop that number to 5? Are we doing anything here that might, I don't know, curtail competition?
Representative Reinders, I don't know the answer to your question. We felt that there had to be some type of reasonable threshold before you get this significant type of concession from the state. And while I said what the state would be giving up is not as great once these two things happen, and one has already happened, Medicare D, and the other one being the managed care, nonetheless, there is going to be give up, and I'm sure Mr. Doubly will detail some of that for you. So we felt that it needed a reasonable threshold.
Anybody else? Okay, Chairman Brown, we have some testimony from the department, I believe.
Thank you for the opportunity to address you regarding House Bill 1459 this morning. My name is Jerry Dubberly. I'm the Director of Pharmacy Services for the Georgia Department of Community Health. This bill would remove the ability of the department to utilize tools such as the prior authorization program, supplemental rebate program, preferred drug list, step therapy, appropriate quantity level limitation management program, and any other reasonable concurrent clinical utilization management tools when it comes to medications produced by these manufacturers that meet the qualifications in this bill. The removal of this ability would impact the department in four major areas. First of all, utilization. There would be an increase in the marginal or unnecessary utilization of medications. We use these tools to make sure that drugs are being used appropriately and in accordance with best practices and the clinical evidence that's available. Additionally, the utilization edits are also used, and they're very helpful in detecting misbilling and even some unfortunate cases such as fraud. The second area would be in terms of cost. By increasing unnecessary and marginal utilization and by allowing less cost-effective therapies to be utilized, we would, of course, be increasing costs substantially. The department currently produces or promotes the use of less costly medications through these tools that I've identified here. We did go through the exercise that was referenced earlier this past summer, where we looked at the effectiveness of these programs for both the state health benefit program and the Medicaid program. Medicaid historically, or at least in the first year of implementation, these programs saved $36 million for Medicaid and $10 million for the state health benefit program. Now, you did hear testimony that the lives on Medicaid side certainly decreased with the implementation of managed care and with the Medicare Part D. That is true. What we are also working on are certain efforts where we would pool our lives with other states that have smaller number of lives than what may be attractive to pharmaceutical companies, and looking at options such as a pool where we take those lives, and our 200,000 lives at that point then becomes over 5 million lives that we take to market to get competitive bids from the manufacturers. The patient safety is certainly an issue. What we're talking about here is eliminating programs that are in place to help protect patients as well against inappropriate utilization. So this bill would, in essence, place the Medicaid patients and the state employee recipients' health and possibly lives at risk. The appropriate clinical utilization tools that we use would be eliminated. And, of course, from a clinical standpoint, we use these tools to make sure that the use of the medication is appropriate. We have to make sure that we are fiscally and clinically responsible with the taxpayer money. I think really to distill this, economic development through attracting and retaining these lucrative companies is very commendable, but I would submit that there are better ways to do that through tax breaks and other economic incentives rather than allowing the inappropriate, unnecessary utilization of pharmaceuticals and possibly placing the lives of these recipients at risk. So I'll keep my comments brief and see if you have any questions for me.
Anybody have any questions, comments? Chairman Brown?
Would you mind if I ask a question?
Sure. What's your number one?
What? Yes. Mr. Dubberly.
Yes.
Chairman Ron Stevens sent me a note just yesterday, and he said that if we really wanted to save some money, and he estimated somewhere in the neighborhood, and I'll grant you it's a wide latitude between the pharmacists, I think he has some basis of fact, that we could save $30 to $80 million if instead of having these prior approvals or
supplemental rebates, that we required the companies to sell at the lowest price to the state of Georgia that they do in any other of the 49 states. Would you comment on that?
Well, okay, this is really kind of the first I'm hearing of it, but we did have last year, we went through an exercise that's somewhat similar, I can walk through, and actually with the proton pump inhibitors, the meds for ulcers and GI erosion, we went through and said, okay, if you're a manufacturer that gives us, if you have a clinically appropriate product, which they're all therapeutically equivalent in that category, so that was a no-brainer. We said, if you're giving us the best rebates in that category, we're going to take back that clinical prior authorization. We're not going to say that you have to have a diagnosis that it was indicated for. We're not going to go through and do that check. We're not going to see if you're stepping patients down like you should be according to guidelines. We're not going to do any of that. We're just going to allow open access for your medication. And what happened was the utilization skyrocketed. And just March 1st, we had to put that edit back in because patients were getting it for heartburn. Patients were taking it because of their lack of ability to control their diet and exercise and those type of things. So the utilization actually skyrocketed. So that's one real-life example where we did just that. We said, if you're offering us the best price in this category, we're going to take back the clinical prior authorization. And the utilization really skyrocketed, and we had to re-implement the prior authorization March 1st. There are other issues with that, with trying to figure out, well, what is the best price that you're giving any other state, for example, because those contracts are confidential and they have not historically been able to share those with us. I would submit that, in response to that, if we look at that situation, if one of these manufacturers that operates in Georgia makes a proton pump inhibitor in that category, we wouldn't be able to do what you're recommending. So we have, to some degree, implemented what you're talking about, and it really has skyrocketed the inappropriate utilization.
Mr. Chairman, may I ask one last question? As you're aware, we put into the 07 budget in regard to the proton pump that you must use the over-the-counter drug. And we have been told by Verizon that in 90+% of the cases, and we've seen some other clinical evidence of the same thing, that will suffice. For those 9-10%, they're going to have to go to a Nexium or something like that that's 4 times more expensive. What would happen there if we're using that as an example? I almost call that a formulary. I don't know if I'm using the correct definition. That if we took what Chairman Stevens is talking about, the lowest price, in combination with a formulary, then the problem you described, interestingly, in the same category of drugs, would that be workable?
It would, as long as we still had the ability to make sure that it was for the appropriate diagnosis and being utilized appropriately, which gets us back to the prior authorization. Interestingly enough, with the example that you used, I can't disclose exact price, but Nexium, which is typically over $120 a script, costs less than generic omeprazole for us. So what looks reasonable to some of the people outside in practice who see the normal cost of the medication across the counter don't have access to our actual cost. But to answer your question, yes, that would be a reasonable approach as long as we still had the ability to make sure it was for the appropriate utilization and used appropriately, which would take us back, unfortunately, to PA.
Any other questions from the committee?
Yeah, just, will we hear again from the author of the bill just as a wrap-up?
We probably will in full committee.
Okay, thank you. That's all I have.
You made a statement that this could possibly put people's lives at stake.
Right.
Explain that to me.
Well, we utilize our prior authorization, our clinical management programs in a lot of different ways. So I guess I can just throw out a few examples. One of the sponsors of the bill makes a product that's used for eczema, for a skin disorder. And that product has been shown to cause certain types of cancers in children less than 2 years old.
Isn't that prescribed by a doctor?
It is prescribed by a doctor.
So what if the doctor thinks it's right for the patient, where's the problem?
Well, the problem is that some of the physicians that are utilizing this medication aren't as familiar as they should be with it. That's the unfortunate truth. I actually had a pediatrician hand me some samples when my daughter went in and she had a patch of dry skin. And so it floored me that even a pediatrician would hand over a medication that can possibly cause cancer in a child just to treat dry skin versus lotion.
You need to change pediatrician.
There are a lot of those out there.
Number 20.
Mr. Chairman, I also be recognized for the purpose of the motion at the appropriate time.
Any further questions from anybody?
Mr. Chairman, I'd like to recommend that House Bill 1459 be recommended to do that.
Is there a second? All in favor say aye. Any opposed, no. Thank you, Mr. Chairman Brown.
Thank you, Chairman Rogers and committee members.
Okay, next is, I do. You got to be here on time to get a copy. No, I'm going to do it for Chairman Hartman. Chairman Hartman wanted me to move to full committee, so that's what I'm doing. So most of you have had a chance to read the bill. It deals with the coroners throughout the state. Well, let me show you. Let me tell you what I'm going to amend. Line 19, where it says 35%, we're going to drop it to 20%. Line 8 on page 2, 8 through 11. We'll strike that. Correct. That's all right. That's okay. And then on page 3, line 12, where it says 50%, drop it to 25%. And line 34, where it says 2005, be changed to 2006. July. You want to change it to January? Okay. No, July. We could.
All right, so a candidate fits in the candidate fits in that 20,000, 28,999 category population. They're going to end up paying 18,399 for.
Chairman Smith, if you want to strike that, you can strike it
No,
off.
I'm just asking a question about how my candidate pays $4,200.
Plus so much of call, so much of case call,
$4,200.
period. Mr. Chairman, you have a geographical label on this? I got one at my office. If you like to come down and look at it. Yeah, I think that's what we're trying to do, is just get it to the full committee and.
Mr. Chairman,
Yes.
line 21 on page 3. Monthly vehicle allowance.
Mm-hmm. Chairman, this is pretty drastic. Well, I agree.
What are they doing with it? Why you want to get it out?
Chairman Harvin wanted it moved to the full committee and let it run its course. So I was just trying to oblige him and get some movement on it if we can. So I know there's a lot of concerns about, especially the smaller counties, and of course the local legislation, that's already set in place will take care of the needs of certain counties. But I think there's being in the funeral home business, I can tell you these guys, what they do, it's a tough business. Of course, they choose to do it, and I know they choose to run for it.
Mr. Chairman, just thinking out loud on that. Remember the bill that we had on indigent kids, and there was a couple cases of which counties were advocating to be able to opt out. Is any kind of language for the populations under certain now, is that possible?
Sure, absolutely.
I'm again with Representative Smith, and somebody sitting in a Webster County or Lee County with 20,000 people, and we don't take them up.
Well, Chairman LaRue's can do it on an open rule basis too, if it hits the floor of the House.
Some of them got less than 20,000.
Well, I agree. I know there's still work to be done on this, Representative Ray, but I'm just ready to move it out of here to the full committee. You vote against
I'll do that, but not like that.
it. I do not. Not necessarily.
Chairman, just from actual experience in here, while I tell you that sometimes we make mistakes by putting these pay raises at a certain percentage of the over and by locking them in like that. Generally, local officials never have to come back to see anybody.
Well, that's the reason I struck on page 2, that cost of living. I understand. Yeah, I agree.
The relationships are stronger when you have to work together to get something done.
I agree 100%. Any other concerns? I know they're concerned, but all I'm trying to do is get it to the full committee.
It's not Chuck's getting ready to run the car.
Chuck's not even here, and
What I mean, this county, he gets paid more than they're getting certain.
he must be sick. I don't know what's wrong with him. He's sick.
Maybe that's what this one, this county. This county is talking about 29 to 38,000. He gives like 3,000 already.
Yeah. And they won't talk back either.
Will not.
Well, let's move to the full committee, and then y'all can do what you want to do. That's okay. You're welcome.
So moved.
Second. Did I hear a second? All in favor, say aye. Any opposed, no. Thank y'all.
Not necessarily.